Good afternoon to all. I'm going to present a project we have been doing with George before his position in Coulommiers. It was a project we did together about surgical instrument traceability and scanning. Just a few words about our hospitals. We are a middle-sized intercity hospital serving a population of about 400,000 people. 650 beds, about 450 beds in acute care. We have medical, surgical, and maternity. 50 beds in physical medicine, and 170 beds psychiatry. We also have, which is something it's our hospital. We are Charles de Gaulle Airport Hospital, so if you ever have a problem in a plane landing in Charles de Gaulle, you will hand in my hospital. And we have an outpatient clinic and pharmacy inside Villepin Detention Center, to say that's about 650 patients. So it's increased our outpatient clinic by quite a lot. So I'll give you an overview of instrument and implant traceability in our project. I think that everybody knows that bit of the GS1 supply chain from the supplier to the hospital, with a focus on the hospital. So we had the area going from the pharmacy warehouse towards the operating theater, to the medication delivery and administration, and to the operating room. So we have a project, was the first one we did, and we are going to speak about is the one about instrument traceability. So what was the goal? Full traceability is mandatory, and French pharmacists, that I think it's why in France, we are very much working on sterile medical devices, is that the French pharmacists are responsible for them the same as for drugs. So they are personally liable. So it gives quite a big incentive. What the challenges? It was managing all those projects which were linked together, because you must go from, reception in the warehouse up to all the supply chain and patient stay in the hospitals. With, as usual in hospitals, I think you must all know that, too few resources, always the same pharmacist doing all the jobs. Their, operational job and managing the projects, and also difficulties with the IT resources. So we had an initial business issue on surgical instruments, which is in France due to Creutzfeldt-Jakob risk. The last 5 patients on which the instruments have been used must be known, so it will always go like that. And it applies to hospital-owned or loaned instruments. We had a secondary business issue for surgical instruments, was that we were hoping, and now we have contracted, for taking the sterilization of another hospital, which is about the same size as us, and at the same level of activity, but have different surgical procedures. We had a business issue for implants and high-value medical devices. Implants, even before UDI, traceability was mandatory, and it's going further on now. And also it's for some drugs and for high-priced medical devices as implants. It's not included in the hospital bundled payment, but it's billed to the patient. not really to the patient, but to the social security account of the patient. For instance, a hip implant is not in the bundle payment for hip prosthesis. Who helped us? It was the head of the pharmacy, Alexandra Fabreguet, well known in our hospital and in a part of France. She has been the leading sponsor, but it took about 2 years to convince the management to go to a full GS1 hospitals. And the problem, I don't know if you're in your countries, but the problem is that in France, the whole administrative management change about every 4 years. So you must go back explaining. We stay, they go. So just to give you, I'll go quite quickly, a view about how many instruments we are talking about. You see in the yellow is our hospital, the other one is subcontracted hospitals. When you see containers, you see it's about the same numbers of each. Afterwards, we use more individual instruments or not. Some are unique use, but traceability very much concerns containers also. So what was the process and instrument traceability? Oh, it's quite what you have all seen. So it's reception of any implantable medical devices going to afterwards to the operating theater. On the other hand, you have the sterilization unit with pre-cleaning, cleaning, packaging, and sterilization going to the operating theater and back. And in the pharmacy, you have also the traceability of the implantable medical devices, which must be recorded and afterwards sent for reimbursement. So how did we begin? At first, we looked, and Georges mostly looked at what could be done. 2 carriers could be used. That was data matrix to the barcode or RFID tags. We were very pragmatic. We chose the data matrix 2D barcodes because we knew it could be laser marked on existed or on new instrument. It cost much less than RFID, and we had the software that could use it. So we could implement it. Why GS1? GS1 because the head of the sterilization unit didn't think, and I really agreed with him, that our sterilization agents are not experts, are not going to be experts in marking the instrument. And we wanted to buy new instruments which were already marked with GS1. And in France, we had one supplier who was marking his surgery instruments like that. And we knew of GS1, and I must say we were very much helped by our MO Valérie in France. So the first step is we did the laser engraving for operating theater instruments, and we choose to put info dots for all the wards instrument because it was much less expensive and it was going quickly. What was the challenge? The principal challenge was logistics because 300 instruments could be tagged per week. And we had to send them to the supplier and get them back. And when we had, instruments which we had quite a stock use quite often, like cesarean, you could send some. We always had some to do the surgery. Of course, when you have instruments which you use 1 or twice a year, It's always when you send it to be engraved that you need it. So logistics were really the challenge. Concerning codification, we just choose a JITIN for all instruments engraved under our responsibility, and we put a serial number. And afterwards, the link was done in the database with the article number. For the packaging, each packaging container has its own supply code, and it's labeled with a unique number at each sterilization process with a barcode. So traceability at the instrument level is done in the packaging area when we link the instrument. You'll see a short video. When you link the instrument to the container, so that the link is done in the database, and after you follow the container. But the link always remains. Globally, we always keep the link between the patient, the container, the instrument, and the process, because we have the load number of the process. And beside that, behind the load number, you have all the technical data of the process. So that link is always kept. Je clique. Non. Ah, click over there. Yes. There's no sound. So they scan the instrument, the container, and they always identify themselves by barcode too. And we have, the list of all the instruments which must be in the box, and you check at each time. And you cannot close the box and the label cannot get off to put on it to go through to follow the sterilization process if the box is not complete. Yes, we print a label because yeah. It cannot be printed if not complete. So effectively, that's one of the first points in, we reduced the non-conformance in the surgical boxes. So it means that first, you don't have a surgeon which is saying, I haven't it, you have to open a new box, and you know what that means in an operating room. And afterwards, due to cost, you have 2 or 3 boxes open, and they come back and you must re-sterilize them. And it's also that was the contractor which was doing it at the time, and he was also doing repairing the instruments we sent for them. So it's also traceability for all what is done on the instruments. Laura. So that's the second step. In mid-2012, we had a new subcontractor, and we then had on-the-spot engraving by the subcontractor employees with two techniques, microdots or laser engraving. So with that, we did all our instruments, including wards instruments, are engraved. And as we got the outside, the contracted hospital, they got their own GS1 number, and all the instruments were engraved with their number. So we can, when you scan instruments, you can know to which hospitals it belongs. The big improvement, that the challenge we had was logistic, and the big improvement is logistics, because when you get an instrument and get into cleaning, after being cleaned, it goes to engraving and goes back to cleaning and into the process. So you don't have that week delay. You had to send instruments to the contractor. And now where are we? But we have engraved all our instruments. So we couldn't keep somebody from the contractor in our hospital. So the marking is only needed for worn-off instruments, and new instruments were not engraved by the supplier. So we acquired the dot engraving machine. We had some training for 3 sterilization operators, and if needed, laser engraving will be done by the subcontractor on the site. And for purchasing, we include GS1 marking in bid to tender, and as was said before, we can't say it's mandatory because it would be against public, bid to tenders. But we can say it's something which is important and will give a higher rating to the supplier. We have suppliers, it's okay for operating room quality instruments. For world quality instruments, we have less suppliers which are GS1 compliant. The remaining challenge, which is one I think is about all over the world, because I had some of my Australian colleagues contacting me and they were so far away on that. When the instruments are not engraved, and it's going from hospitals to hospitals, sometimes you have to send them back quite quickly, and it needs a comment request by the health provider, but we think that now that we have UDI, that will really help because they will have to. So it's engrave your instruments or die. I won't go into the details, but just to show you, that was good afterwards for my CEO. We had a return on investment of 24 weeks. Due to part to the reduction of the non-conformity sterilization of the containers, but mostly it was done in human resources, because before, I think, like in a lot of sterilization, you have the operating room nurses which were going down to do repackaging, because they knew the procedures by heart, so they could repackage. And now, as you have the list, your BIP, we use much less skilled operators. They are skilled, but not in the same area. And operating room nurses are needed in the operating rooms, not in the sterilization area. So we just we just have 2 of them, but they couldn't work anymore in the operating room, which are team leaders and referents. We have 1 for each hospital. So that's something you can do because it can show your CEOs that you have a very quick return on investment. And it's human resources, which is always very important when they hear that 70% of the budget of a hospital. So how did we do it? I must say we did do it because we had George. Don't look like that. He was a great sponsor. He had no prior knowledge of GS1, but he has really the will to learn and understand. And he was very open to all ideas. He was a very strong project leader, and he helped convince the top management. And also, he was a recognized team leader by his operators. And we had a newly refurbished sterilization unit done by George. And the operators were used to be, included in the project. They participated in the new design and the new organization. It was a young team scanning. They were used to scan the boxes, containers, the ID. Scanning for them was quite something simple. And they were kept and informed, and they participated since the beginning of the project. And they were proud of being the first to implement, and they were very proud to have people coming to visit the sterilization unit. And it was really a team spirit. But for that, you have to have a leader. And there was, what I say, immediate acceptance and even enthusiasm. The K challenge, what you must know, first problem was our engraving supplier. We just had, he was monopolistic. Second thing, the things you must know that for instruments, the scanners are the biggest challenge. To be able to read the data matrix. So don't try to engrave too small if you can engrave a reasonable size, and look for the scanners. Afterwards is what you know for everything. It's interoperability with between all your IT systems. But I think it's a problem we all face. What next? Now we are tracing. We are going to manage all the operating theater stock. By the pharmacy will do it. We have a warehouse management system in the new medical device warehouse, and we are trying with automated dispensing cabinet in the operating rooms, or scanning, or trying to find which is the best solution. And what we are doing also, it's the complete integration with the the electronic patient record, which is nearly implemented in the hospitals, and to have direct traceability beginning also in the operating room. Here we are. I 4 minutes.